HIV care at BJ Medical College and Civil Hospital, Ahmedabad. He has actively contributed in developing treatment protocols for diseases like COVID-19, leptospirosis, mucormycosis. He has more than 35 noteworthy papers published in national and international journals. We welcome you, sir, for today's session and request you to start the session.
जी नमस्कार.
Namaste, sir.
Respected authorities and various participants in this regional distance learning seminar series. I welcome you all. Give my regards to your parents, your in-laws, your teachers and your elderly, and my love to your kids. Today my topic is a non-communicable disease and mental health, prevention, screening and management among PLHIV.
So slide पे click करके फिर next कीजिए please.
Today we'll cover the what do we mean by non-communicable disease, hypertension screening, diagnosis and its management, diabetes, a second one, NCD, cardiovascular disease, risk factors. We'll cover mental health and common cancer also, which are common in the HIV patients. We will cover non-communicable disease among the people living with HIV. Since the increased ART coverage, PLHIV are virally suppressed, are living longer and require comprehensive health and well-being approach. Over the last 25-26 years, the country's disease pattern have shifted. Mortality due to NCDs are increasingly contributing to overall disease burden. NCD caused by a combination of genetic, physiological, lifestyle, and environmental factors. Let's see. In a cardiovascular system, we have mainly hypertension, ischemic heart disease, cerebrovascular stroke, and rheumatic heart disease. This is quite common. Rheumatic heart disease particularly is quite common in the third world countries, developing countries also. Respiratory system includes asthma, chronic obstructive pulmonary disease, occupational lung disease. There are people who are working in a coal mining area or asbestosis, or those who are busy in this quarry business where stone cutting industries is there, where you see silicosis and other diseases. The farmer's lung and the people who are working in farm, those who are working with the cotton, they are also having a vagarosis like occupational lung disease. Then cystic fibrosis and pulmonary hypertension are examples of non-communicable disease. Endocrine disorders like type 1 and type 2 diabetes, pre-diabetes, and among the pregnant ladies, that is gestational diabetes. And in renal conditions, we have a CRF. They are commonly what we see with the HIV patients. In a central nervous system or a psychiatric illnesses, depression, anxiety, schizophrenia. In hematological disorders, anemia, nutrition anemias, hemoglobinopathies. Patient may already have an underlying hemoglobinopathies or sometimes drug-induced anemia. In a cancer, we have a breast cancer, cervical cancer, lung cancer, oral cancer, prostate cancer, colonic and stomach cancer in the GI system, and more commonly what we see is the leukemia, lymphoma in the HIV patients. In musculoskeletal disorders, arthritis is one of the common side effects of drugs, as well as the cachexia and other factors also contribute to the arthritis. Now, what do we want to do? Health promotion. We have a primary care, secondary care, tertiary care. Before primary care, before disease appears, we say health prevention. And before the health prevention state comes, that is a health promotion. We should provide them such an environment, we should train our patient also, so that we can promote them for healthy lifestyle, so that they don't develop some non-communicable disease. Hypertension, diabetes, stress is also one of the major risk factors. Less working habits, sedentary lives, all of them are contributing to the metabolic disorders, NCD, like diabetes and hypertension. So, by promoting the health activities like regular walk, diet control, and how to remain cheerful, and that stress-free life will either delay or it will not end up with the non-communicable disease in the any group. Particularly, we are talking of HIV patients. So health promotion is our major focus. What will any patient who is coming in our OPD or those who are indoor, every time we promote them so that the lifestyle is good, they walk regularly, they watch their diet, so that promotion of the health is a step ahead the health prevention. We'll screen early detection, so we'll discuss about various diseases, which are the early symptoms, to whom we'll screen. We'll discuss that, how to diagnose the disease, and how we manage with the lifestyle changes as well as drug therapy. We'll discuss in the individual disease. After, once you diagnose a disease is there or not, with the screening, we'll screen them, we'll diagnose them. Those who are found normal, we'll promote them regularly, that you continue your lifestyle modification so that you don't end up with the lifestyle related diseases. And those who are developing signs of disease will start the treatment as per the protocol, and we'll have a regular follow-up these cases, so that if the disease is found, we'll monitor their control. If the disease is not there, we'll see that the patient cooperate to us, and we can delay to some extent the appearance of the non-communicable diseases. During the follow-up, we'll also monitor about the whether a target is achieved, blood pressure target or sugar control target is achieved or not, and are there any drug side effect and some drug-drug interaction with the HIV medicines and antihypertensive, anti-diabetic drugs are there or not. We'll monitor that. The health behavior which affects the outcome of any disease, we'll focus more on that. This is a physical activity, at least 150 minutes per week. That includes every day 30 minutes fast walk, 25 minutes to go, 25 minutes to return. 15 minutes to go, 15 minutes to return. 30 minutes per day and 5 days in a week. Saturday, Sunday, holiday, we can allow. So 150 minutes in a week, we'll promote that. There should be a fast walk, no slow walking. Hi, how are you? Not like this. You concentrate on your walk, and you should have a perspiration that much, so that you have enough speed is there. If you walk, instead of walking, if you run, then there are chances that you may damage your joint. But fast walk is very good for the muscle mass development, and trauma to the joint is less. Other than fast walk, you can go for swimming if it is possible. That is a swimming is a best exercise in a weightless position. That's why we should promote swimming. Those who are already obese, those who are having a tummy out, their waist hip ratio is more, waist is more, stomach is out. Those who are obese people, what we'll do? We can start, first of all, regular, let them do a cycling in the air. Let them do a supine position, have a cycling in the air, so that the muscles are toned up. Try for 1 month, 2 months, 3 months, and then go for the walking. Otherwise, obese person, if he or she will start walking immediately, he may end up with a backache or some muscle pull or something like that. So don't be aggressive. It should be a gradual process, and you should promote them gradually, so that the lifestyle, the physical activity should be a habit of the person, so that he walks regularly. Yoga and meditations are good for relaxations. Every day, after taking bath, you be with yourself, and at least for 30 seconds, You increase from 30 minutes, 30 seconds to 1 minute, 2 minutes, 3 minutes, 10 minutes. So that relaxations, you can bathroom. I feel comfortable where you are with yourself, and otherwise you can decide your own place. But at least sit. Don't stand up. Don't lie down. Sit up without taking back rest. And in a Padmasana position, you sit and close your eyes. Let the thought to come and go. Let the thought to come and go. Don't try to concentrate on that. Just concentrate on your breath. The breath is coming out, breath is going in. And that sort of a yoga. And there are some yogic exercise, yogic capsules are there. Capsules in the form that you have a physical exertions, and then you have a breathing exercises are there. Yoga is equal to Jodhana. You have to unite with yourself. Mind-body complex. So first step of the yoga is you concentrate what you are doing. You concentrate on work. When you are eating, concentrate on the eating. When you are sleeping, concentrate on the sleeping. When you are reading, you concentrate on the reading. Yoga is equal to you connect yourself. You connect your mind, body, soul complex, or you connect with your exterior, your family, your surrounding, your community, your nation, and whole this world you communicate. You are a part of the whole galaxy. You are a small part of the galaxy. Your whole galaxy is within you. That way of living is yoga. Yoga does not mean only breathing exercise or some pranayam, asana, and no. It's a beyond that. It's a way of life. That concept must be there in the mind of we, the doctors, and all healthcare workers who are giving training to the patient and our colleagues. Weight control. Weight of management is a main, you have to, weight gain is there. Then in HIV patients, we see lots of weight loss. We start therapy, they put on the weight. So that's the thing. With the fat is increasing or a muscle is increasing. That we have to concentrate. So as per the height, what is the BMI of the patients? Number one, that will monitor in every patient. Number two, if they are low BMI, we have to increase the body mass also. When you are increasing body mass, see that the muscle mass should increase more rather than fat. So that we have to keep in mind. Those who are already obese, having some diabetes or hypertension, they require weight maintenance. So weight is, we have to, first of all, on day one, what is the weight? Whether it is as per the ideal or not, more or less. If it is more, we have to reduce. Be gradual, and we have to, weight reduction should be there with the control of diet. And second thing is exercise. Then once you do start exercise, initially the weight loss may not be there, but don't worry. Once you are working, maintaining exercise, you are increasing your muscle mass. That is to be kept in mind. And second thing is oil consumption, hypertension, diabetes everywhere. The oil will come as a food. So per person, 20 ml oil, edible oil per day. I'm repeating, 20 ml edible oil per day. That should be the recommended one, so that suppose there are 5 people in the family, more than 11 years of age, all adults, then your oil intake of that family should be 100 ml per family per day. For children below 11 years of age, we can allow them 40 ml oil per day. And which oil is better? The people will ask here and there. I will not discuss here about the omega-3, omega-6. I will not discuss. Omega-3, omega-6 ratio is important, where ideally is 1:4. It is 1:40 in ghee versus 1:140 in a sunflower and safflower oil. So ratio is more. But what will happen? It will not only reduce LDL, but it will reduce HDL also. HDL, which is good for the body. And that's why I say it is not the quality, it's a quantity of the oil which is matters. And that's why you go for the 20 ml oil per person, adult person per day, and that will be definitely helpful you in the weight reduction. those patients or person who are overweight or obese should be encouraged to lose weight through combination of the low calorie diet, dynamic physical activity. Just I am saying about the chapati. The whole grain chapati or whole atta is better than the refined atta like manda. And so simple roti, what you are eating is far better than the fast food which are using the refined atta, or they are very fine refined. So fibers are broken in the refined atta, and that's why they are more harmful to the body many times rather than help. So we should take care of that. In this year, we are focusing on the millets. So millets in the diet should be encouraged so that at least your fiber is completely more. Those who are affording, they can have a fruits are there. If the diabetic is there, then sweet food, what every food has got glycemic index. So fruits having high glycemic index like banana or sweet melon, or where the sweet is more than even sweet grapes also, they have a high glycemic index. So we should eat low glycemic index fruits. Diet, as we discussed, locally available items should be preferred. Salt restrictions is important thing. Instead of many people are using table salt in the form of a sandha namak, or that is a salt from the land, or rock salt, what we say, rock salt or salt from the sea. All are basically equal, and both of them having a side effect that to be kept in mind. Important thing is other than human being, no animal species are using salt in diet. Salt is good for the taste, and salt taste is basically developed in the human being later on in the evolution. So it is not salt is not a basic taste. So without salt also one can have a food. So lesser the salt, better the outcome as far as blood pressure is concerned. Those who are having a kidney problem and those who are having a hypertension, both of them should have a salt restricted diet that is equal to 1 teaspoonful or 5 grams per day. Elderly people, those who develop particularly summer where perspiration is more, where you are losing sodium from your perspiration, you are losing. There are conditions where you are hyponatremia, where you require to give salt. So those who are having an altered behavior with hyponatremia will require sodium. Usually we give in the form of IV sodium chloride. Otherwise, for routine diet, less salt is always better to be kept in mind. So all patient people having congestive cardiac failure, diabetes, kidney failure or hypertension should use salt restricted diet. Tobacco and alcohol, there are two abusing material. Tobacco, we know primary smoking, secondary smoking and tertiary smoking. Primary smoking, when I am taking smoking or tobacco I am using in any form, it's a primary, I am taking tobacco. Secondary, my nearby bystander is smoking and I am getting smoke in my inhalation, that is secondary smoking. And tertiary smoking is when pregnant lady is smoking and the fetus is having some side effect of smoking, it is known as a tertiary smoking. So tobacco in any form, it may be a dental cream, it may be a snuff, it may be a pan, gudka, or it may be in the hookah or e-cigarettes. Any form of tobacco must be discouraged completely. The tobacco is if you put the tobacco in the mouth and if you measure the blood pressure will be 20 millimeter more. So if whenever the patient is coming to you and his blood pressure is found high, ask him, have you put a tobacco inside? Ask him to remove the tobacco and it will reduce the blood pressure. So these are the common things you should keep in mind. Ji. So, we should strongly advise all smokers and tobacco chewers to quit tobacco completely. And we should, once they stop tobacco, there are some alternative available where they alternate chewing tablets are available, nicotine, low nicotine content tobacco tablets are available. One can take advantage, but to maintain the nicotine level, sometimes they chew more tablets. So sometimes that is also to be kept in mind. But family support is required, colleagues and friends support is required to quit the tobacco or alcohol, to be kept in mind. Avoid alcohol, everyone should avoid the alcohol. We have a, Gujarat is a dry state, but we have other states where alcohol is permitted. Remember one or two things. Female absorb double amount of alcohol. That's why the alcohol recommendation is half in a female as compared to male. So if the beer is allowed 30 ml for male, then for 50 female it is 15 ml. 1.5 because the absorb double. That is one to be kept in mind. Alcohol is sometimes medical ground people take, but ideally it should be completely stopped in all patients. Counseling of the people with alcohol use disorder and drinking in excess of moderations. Why counseling support is required? In alcohol, there are two. One is a psychological dependence, and second thing is a physical dependence. Those who are in psychological dependence, early users will be come out with the counseling. The doctor will request father, and father will stop. Emotional background, they can stop. If it is a psychological dependence is there, but if he has reached to the stage of a physical dependence, then he may require drug therapy, de-addiction center treatment for the alcohol, to be kept in mind. Adherence to treatment, either diabetes or blood pressure, all alcohol, de-addiction, any treatment adherence is a key factor in long-term management of the disease or habit. And that's why if the person is prescribed medications for NCDs, explain the doses, how many times to be taken, empty stomach or without or with the food. Explain them how to take the ARVs along with the additional medications. Explain the importance of the adherence to the medicines for NCDs along with the ART. Explain the need to take the medicines regularly as advised, even if there are no symptoms. These important things. People think that whatever I had early morning headache was there, hypertension is treated with the medicine, the headache is not there, they will stop it. So we have to ensure them repeatedly. They are illiterate many times. So we have to repeatedly ensure that they are adhering and they are taking treatment regularly, even if their symptoms are relieved. Counsel on the possible side effect and advise to report back immediately if side effects, adverse drug effect reactions are experienced. For every medicine, say amlodipine will produce a constipation, or enalapril can also sometimes on the first dose hypertension is reported. So when you start for the day one, patient may have a first dose hypertension. So common side effects to be kept in mind. Let's start with disease-wise. Hypertension, screening, diagnosis, and initial management. All to whom will screen? All PL-HIV patients above the age of 18 should undergo screening by the healthcare worker through BP monitoring. When we will measure at the time of registration into HIV care or ART initiation, at the first, anybody who is more than 18 HIV positive will measure blood pressure at the time of registrations. Every 6 months after ART initiations or separately as a screening examination if required by the PL-HIV or need felt by the healthcare provider based on the symptoms. The screening should be done by the physician using a validated devices following standardized BP measurement. If the person is obese, that small pediatric size cuff is not there. The back size of the BP instrument cuff should be appropriate as per the, if the patient is obese 100 kg or more, will require wider bag. Remember one thing, 2/3 of the BP cuff overlap should be there, so that blood pressure is measured perfectly. Prefer in a sitting position. Arm must be rested on the table. It should not be hanging. Don't measure in a standing. Patient must be in a sitting position, comfortable. Let him to sit for 5 minutes, 10 minutes, and then measure. He will just enter in your chamber, sir, BP, have a measurement, and come back. This is not good thing. Ensure that there is no tobacco in the mouth. Otherwise, it will also raise the blood pressure. So that's common thing. Doctor must be relaxed. Patient must be relaxed. Then the measurement with a perfect BP instrument is good. The BP, if you are doing mercury level or electronic, it should be at the level of heart, so that blood pressure is properly maintained. There are the few basic things we know during our training, but we'll maintain that. We should take the two blood pressure, right and left upper limb blood pressure measurement should be taken on day one when we measure, go for the, and higher should be considered as a higher recording is a blood pressure of the patient and not the lower one. If we are, the difference in right and left. Generally on the hand which is used, right-handedness, they will have a bit blood pressure more on that side. It should be based on the at least two measurements taken on at least two visits, which are at least 1 to 4 weeks apart. When we label a hypertensive, at least two visits, two measurements at the distance of 1 to 4 weeks apart. But those who are already having following criteria will start the treatment from beginning. Hypertension is diagnosed during the first measurement of in the case of a hypertensive urgency. There are two words, hypertensive urgency, hypertensive emergency. What is hypertensive urgency? Systolic blood pressure 180 or more, and diastolic or diastolic. So systolic may be normal, diastolic is high. Systolic is a systolic hypertension, where you have a systolic is more, diastolic is normal. So if the systolic is more than 180 or diastolic more than 110 with no evidence of the acute target organ damage. Which are the organs? Remember, brain, where you develop stroke. Cardiac, we see a heart attack. And kidney, where you see a kidney failure. So if the organs are normal, brain, heart, and kidneys are normal, in that condition, high blood pressure is high, it is known as the hypertensive urgency. And hypertensive emergency, where BP is more than 180 or diastolic blood pressure more than 110 to 120 millimeter mercury, and there is a cardiac, cerebral, or renal damage, or fourth one is a grade 3 or 4 retinopathy. On fundus examination, if there is retinopathy, it is a hypertensive emergency. You require admission of the patient, and even at the first measurement, patient may require more than 2 drugs also. That is to be kept in mind. Hypertension should be diagnosed when BP is persistently above systolic blood pressure more than 140 or diastolic blood pressure more than 90 is labeled as a hypertension. Now, additional assessment for the all hypertensive patient, we must also look for the fasting blood sugar to assess diabetes, urinary analysis for the proteinuria. The hypertensive patient may have a kidney damage that leads to proteinuria, or many a times kidney is a reason for the hypertension. That's why we will need proteinuria in early detection of diabetic nephropathy. Generally, diabetes of a 7, 8, 10 years duration, in many cases up to 25 years, they don't develop diabetic nephropathy. But type 1 diabetes develop diabetic nephropathy early as compared to type 2 diabetes. But when the diabetes is increasing in a duration of years, after 7 to 8 years, the risk of diabetic nephropathy is more. Those who are having diabetes and blood pressure, they have more chances of development of diabetic nephropathy. But the initial finding is we look for the proteinuria, and other two tests which are not are the microproteinuria or microalbuminuria, and in many conditions we also measure 24 hours urine collection for protein excretion measurement. So in our program, we'll particularly focus on the protein If the urine protein stick is positive, we refer them to the consultant. Desirable for the PLHIV with systolic BP more than 160 and or diastolic BP more than 100 millimeter mercury. The following tests are required. Lipid profile. You prefer the lipid profile testing in a fasting, overnight fasting should be there before testing. So in the morning, call the patient without taking tea or breakfast. Then serum creatinine level and blood urea level, electrolytes like sodium, potassium, we test for the kidney function assessment. And of course, cardiogram to look for the left ventricular hypertrophy, to look for the arrhythmias, to look for the ischemic changes in the cardiogram. We see. The in hypertension, basically LV, left ventricular mass increases. So wall become thicker, walls of the ventricle become thicker and cavity of the left ventricle will become smaller. So this is known as left ventricular mass increases because of hypertension. That is reported in cardiogram as a left ventricular hypertrophy, and that's which has got prognostic significance. Target for BP control for patient below 80 years of age, the systolic should be less than 140 and diastolic should be less than 90. For people more than 80 years of age, we have to keep the blood pressure slightly higher. So target is 150 and 90 is a target for the people more than 80 years of age. All patients require lifelong lifestyle modification. I am taking pills, so I will not follow salt-restricted diet, or I will not walk. That is not good. So all patients, even if you are taking medicine, the walking, exercise, diet pattern should be perfectly followed strictly. The low-fat diet, regular exercise, weight maintenance target, BMI should be between 18.5 to 22.9 should be maintained, and stop seizures, stop smoking and alcohol should be promoted. Antihypertensive therapy for uncomplicated hypertension, and irrespective of whether HIV status is either mono or combination therapy, the ACE inhibitors are drug of choice. Those who are having kidney failure or where you have a bilateral renal artery stenosis, we don't prefer that. Otherwise, this is a better drug. NRP is a better drug. Angiotensin receptor blocker. ARBs are also losartan, telmisartan, other molecules are coming. Calcium channel blocker like amlodipine, nifedipine are also in use. Thiazide. Diuretics are the main basic drug. Hydrochlorothiazide. If you are, the maximum dose should be preferred is 12.5 milligram hydrochlorothiazide. If you use more than 25 milligram hydrochlorothiazide, your uric acid will be affected, your lipid metabolism will be affected. So whenever we are using thiazide diuretics, hydrochlorothiazide, use less than or use up to 12.5 milligram dose, not to exceed 25 milligram. That is to be kept in mind. Beta blockers are also one of the antihypertensive. Now we always see a combination where the disease, say COPD is there, beta blockers are not good. Those are in cardiac environment, the beta blockers are good. Kidney is involved, angiotensin converting enzymes are not preferred, amlodipine and beta blockers are preferred, and elderly people, calcium channel blockers are preferred as compared to beta blockers. Prostate is there, we'll prefer alpha blocker as compared to other medicine. Patient having a peripheral vascular disease will prefer calcium channel blocker. So as for the other disease also, we will add and will selection of the drugs will be decided. But generally, routinely, what is a protocol will follow? Number one, we'll decide what is the level of blood pressure. First of all, if the blood pressure is more from beginning, we can start treatment from beginning. Otherwise, we have to have a 2 examination at 1 to 4 weeks apart, and then make an average, and then you decide whether the patient requires what is grading of the hypertension. Grade 1 hypertension, systolic is between 140 and 159, diastolic between 90 and 99. And they require lifestyle modification, that is exercise, diet, and yoga, meditation, stress management. And After still meticulous, once you are not starting treatment in grade 1, though they require meticulous follow-up, and if they are not responding, that still they remain, blood pressure is not falling to normal, and grade 1 hypertension persists. In that cases, we have to add the medication with the one drug. That is a grade 2. So grade 2 hypertension is known as systolic blood pressure between 160 and 179, diastolic between 100 and 109. This is stage 2 hypertension, where we start with the one drug therapy, monotherapy with the antihypertensive, with lifestyle modification. Lifestyle modification is a basic phenomena to be observed by everybody, every patient. And grade 3 hypertension, systolic more than 180 and diastolic more than 110. So when you are on first visit, the grade 3 hypertension is there, we will start the patient with a 2 drug therapy straight away. If the blood pressure is really very high, hypertensive urgency, hypertensive emergency ward will keep in mind. Hypertensive urgency is blood pressure is high, 180, 110 or more, and there is no target organ damage. That is, stroke is not there, heart attack is not there, kidney is normal. Whereas hypertensive emergency is PP more than 180, 110 plus stroke, heart attack or renal injury. That is grade 3 hypertension straightway, you require admission and 2 drug therapy. The dose of the drugs can be increased or a new drug can be added at approximately 2 to 4 weeks interval. So have a regular follow-up, measure blood pressure, and then see that whether. One more thing, if the patient is taking morning the antihypertensive at 8 o'clock, then you see the second measurement should be in the afternoon or after 10 hours of the first dose. Sometimes the morning is controlled, but the evening blood pressure is not controlled. In that case, it's wherever possible, you check the evening blood pressure also, so that you can, whether the patient requires additional drug in the evening or not, we can keep in mind. This frequency can be faster or slower depending on the clinical circumstances of the patient and the judgment of the treating physician. Patient with diabetes should be initiated on drug treatment when systolic BP is greater than 140. We label these are a grade 1 hypertension, but the diabetes is there, we'll start the treatment immediately, and the target to be achieved, systolic blood pressure less than 140 and diastolic less than 90. If we control sugar, but if we not maintain this blood pressure of the patient less than 140/90, then kidney damage will be more earlier. So in diabetics, blood pressure control also is of pivotal. It's important to control the blood pressure also. AC inhibitors are preferred as initial therapy, and calcium channel blockers and diuretics will be used as add-on therapy. Initially, the diuretics were the initial first-line drugs, but where you have a renal failure, where you have a cardiac failure, or where the edema is there, in that cases, the diuretics may be added, or with any ACE inhibitors, calcium channel blocker, or beta blockers, if they can be used with any of this. If the blood pressure is not controlled, as a second drug, diuretics should be preferred. ACE inhibitors and thyroid diuretics do not have any interaction with the ARVs. There are potential interaction between calcium channel blocker and beta blockers with ARVs. Drug level of calcium channel blockers and beta blockers are increased in the presence of EIs and protease inhibitors, and decrease in presence of NNRTIs. Dose adjustment of the antihypertensive agent may be required. Second point, drug levels of ARVs are not affected by the calcium channel blockers like amlodipine or beta blockers, and no dose adjustments is required for ARV. Caution should be exercised when administering beta blockers and PIs due to the risk of QT prolongation. QT prolongation can be monitored with the ECG. And now there are app available where you can ECG can be in ECG you can measure the QT is prolonged or not. Now there are corrected QT prolongation app also available. You can calculate through mobile. Why QT prolongation? If the drug is increasing the QT prolongations, then the cardiac tissue is more irritable and it end up with arrhythmias. And that's why we need to check the cardiogram regularly to look for the QT prolongations. So I said the left ventricular hypertrophy, arrhythmias, and QT will measure in a patient who are hypertensive on antihypertensive therapy. Other care and referral system, screening, diagnosis, and treatment of the uncomplicated hypertension can be provided by a trained medical officer. Grade 3 hypertension and failure to achieve treatment goal following initiation and dose increase of 2 antihypertensive to maximum level shall be referred to physician experienced in management of hypertension. So, if it is not controlled with you, refer to the physician. Immediate referral to the appropriate facility and provider shall be done in case of a hypertensive urgency and hypertensive emergency. When blood pressure is more than 180, 110, with or without stroke, heart attack, or kidney failure, we should refer them for admission and further management to nearest facility. Now, second NCD is basically diabetes mellitus. Diabetes, all PLHIV should undergo screening through random blood sugar. Whenever patient is coming to you, measure the sugar. You are pricking the HIV positive patient. So universal precaution to be kept in mind in all the cases when you are doing a needle prick and screening for the diabetes. At the time of registration into HIV care or ART initiation, you do a screening. 1 to 2 months after ART initiations, and then at every 6 months. Once we put the patient on ART, they will have an increase or weight gain will be there. And that's why they should be monitored for diabetes regularly. At change of regime, when you are substituting some regime or we are switching over to some other regimes, at the time also have a look to the RBS or separately as a screening examination if requested by the person. If the person wants to have diabetes check kar lo, to हमें करवाना पड़ता है. The symptoms of diabetes every time, whenever the patient is coming to you and he is looking now plumpy, the treatment is starting and he is feeling better, ask for 3 P's. Polyuria, that is increased frequency of urine, polydipsia, प्यास बहुत लगती है, and weight loss in spite of polyphagia. खाना बहुत भूख बहुत लगती है, पर weight loss है. Polyuria, polydipsia, and polyphagia, and weight loss in spite of polyphagia. We should check the sugar level. If the patient is feeling tired, weakness, generalized pruritus, recurrent urogenital infections, UTIs are there, or vulvodermatitis is there, or urethritis is there, or melanoposthitis in a male is there, we should question ourselves: am I missing diabetes or not? Delayed healing of the wounds anywhere in the body, the delayed healing. That's we should be alert that patient is having diabetes or not. Diagnostic criteria for the diabetes are symptoms of diabetes: 3 P's, recurrent infections, delayed healing, a generalized tiredness, plus casual or random blood sugar more than 200 milligram, fasting plasma glucose more than 126 milligram, 2 hour postprandial or 2 hour post glucose, post 75 gram glucose. Glucon D or glucon C आता है. Glucon C is basically contain vitamin C. So whenever you are using a GTT, glucose tolerance test, prefer glucon D. That is a green packet. Glucon C is basically a contains citric acid and other citrus foods. So which has got, which may give a false positive urine cigarette report. That's why clear one. Use a green glucon D packet. Number 1. It's a 100 gram packet is there. So divide into 4. Make out 25 milligram out. 3 is 75 milligram. At empty stomach, 75 gram glucose to be taken. And after 2 hours, whatever you measure is a post 75 gram glucose blood sugar measurement. And if the 2 hours post 75 gram glucose is more than 20 milligram, it is a diabetes diagnosis. Oral GTT, we take fasting half hour, 1 hour, 2 hour in that manner. It's a spot GTT, what we can say, where we are measuring the blood sugar after 75 gram of glucose. And Last one is a glycosylated hemoglobin. We have our hemoglobin. The lifespan of the RBC is 90 to 120 days. So whenever we do a HbA1c or glycosylated hemoglobin, the component of the hemoglobin which is glycated, that we measure. So that will tell you about the average sugar of 3 months. That is a glycosylated hemoglobin. It has been reported that HbA1c levels underestimates the glycemic levels by 10 to 15% in HIV positive patient. Diabetes diagnosed using any of these criteria should be confirmed with another test subsequently. So if the RBS is 200, we label them as diabetes, but we'll call them in a fasting state and we'll check the fasting blood sugar during follow-up. We'll have a postprandial sugar or post-glucose sugar level. We'll cross-check before definitive diagnosis of diabetes. The blood glucose, PP2BS and FBS and PP2BS, at least once a month we should monitor, and more often if the values are not ideal target, not in an ideal target trend. After starting medicine, if the sugar is not controlled, have a regular fasting and postprandial blood sugar measurement. HbA1c or glycosylated hemoglobin should be measured every 6 to 12 months if available, and more often every 3 months if values are not in the ideal range. Means if diabetes is not controlled, at least every 3 monthly, till it is controlled, we should measure. And then once it is controlled, every 6 months to 12 months, HbA1c should be there to overall monitoring of blood pressure. It is required. Clinical examination needs to be done during the every visit, and minimum every 3 months. Examine the patient clinically. What to examine in diabetic patients? Diabetic patients, remember my one sentence. In diabetic people, if the legs are good, then everything is good. So always touch the feet of the patient, I say, and then start examination. So by touching the feet of the patient, that means palpate dorsalis pedis artery. The dorsalis pedis artery is good, palpable, blood supply is good, because in a diabetes, before the larger vessels are affected, peripheral neuropathy comes. Before the blood diabetes comes in the blood, your peripheral nerves are affected more. So tingling numbness is more common in the legs. So every time, whenever we see a diabetic patient, you examine his shoes, his chappals. They must use a cotton mojadi style chappals which are covering the whole foot, because diabetic people must be taught to, before coming out of the bathroom, you clean the feet properly, you talk to your feet, make it dry, and then come out. Every time we should wash the sole, any hardening, thickening, ulceration, corns in the legs, and then dorsalis pedis in the lower limb. Actually, these are upper limb, but dorsalis pedis, whatever the first, consider as a lower limb. The toe, great toe is there, and then first toe is there. Between these, a web is there. You trace the web, and highest point on the feet is basically a site where we examine dorsalis pedis artery. So palpate that vessel every time you see the diabetic patient in your follow-up. So that is clinical examinations. There are 6 things to be tested. In diabetes also, brain, so osculated carotid, heart, look for any murmurs, and kidneys, 1.25 centimeter above umbilicus and to the left. I'm repeating, carotid vessels, cardiac coronary with auscultation, and auscultation on the renal arteries. That will tell you about the vascularity, some murmurs are there or not, it will tell you. So, 3 major organs and 3 minor organs, that is a kidney involvement, retinal involvement. There are 2 basically. Small size arterioles are affected, or known as a microvascular disease and macrovascular disease. So microvascular disease are basically a neuropathy, retinopathy, and nephropathy are basically a microvascular disease. So 3 things we have to observe. And for macrovascular disease, the brain, that is carotid, coronaries, that is heart, And peripheral vascular disease, that is a gangrene of the lower limb, to be kept in mind. Other than this, the decreased libido, sexual side effects are also seen in the diabetics. Decreased libido to impotence also is observed in a diabetic people. So clinical examinations include blood vessel examination, foot examinations, cardiac auscultation. So 6 organs to be kept in mind. Again, I'm repeating: brain, heart, and kidney, and peripheral nerves, and peripheral pulsations for the vascularity is good or bad. We should keep in mind. Screening for long-term complexes like retinopathy, nephropathy, neuropathy, peripheral vascular disease, coronary artery disease, at least once in 6 months or more often if it is required. Diabetic plus hypertension plus smoker, we have more chances of the macrovascular disease, either cerebrovascular, coronary, or peripheral arterial disease. So, more the risk factor, more frequently you examine the patient, more time to be given to the patient to explain that these are the harmful effects of these medicines, the disease and the habits you should quit. And if you have quitted the tobacco or alcohol, we have to ensure, we have to encourage for maintain, they should maintain that they remain without alcohol and tobacco. Optimize the weight, waist circumferences, and blood pressure and lipid levels with the medicine or with the diet control. Routine examination of the food to be done during every visit. As I told you, you teach or you request or you pray your diabetic people before you come out of the bathroom, have a dry, examine your leg, have a dry leg, because wet leg can have a more chance of injury. Ill-fitting shoes can have a more injuries. That's why diabetic, if the feet are good, then the life is good. That is to be and हम हिंदी में कहते हैं 40 से चलेगा ना चलेगा, एट द एज ऑफ 40 चलेगा तो चलेगा, नहीं तो गया. इसलिए रेगुलर वॉक इज इंपॉर्टेंट एट द एज ऑफ 40 years. Discuss the tobacco and excess use of alcohol. Which are the blood tests other than sugar report? We'll go for lipid profile, serum creatinine level, and urine analysis for proteinuria. As I told you, microalbuminuria, and then frank proteinuria, and then 24 hours urine protein examinations in some selected cases. So, urine for proteinuria, we can check with the strip also. So that is possible. So diabetic are losing. One thing is important thing to be, I want to bring to a notice for lipid profile, have a fasting sample, overnight fasting sample, no morning breakfast, no morning tea or chai coffee, and then you take the sample. That is one. And for urine analysis, they should withdraw the trapezoidal skin properly, clean the genital parts, male or female, local examination, local cleaning with the water should be there, and then midstream urine. Don't take initial urine, don't take last urine. Midstream urine to be collected directly in the test tube. That's the best way of measurement of collection of the urine for examination to be kept in mind. Treatment of the diabetes for patient with pre-diabetes. Pre-diabetes is something before diabetes appears. So pre-diabetes, abnormalities, but do not meet criteria above the diabetes. Monitoring with the FBS or FBOC, if available, every 6 months, and encourage lifestyle modifications. So pre-diabetic people, ensure that they maintain lifestyle modifications. Every time say lifestyle modification include diet, exercise, and stress management. 3 things to be managed every time. Lifestyle modification is mentioned under the health promotion, is recommended for all PLHIV diabetes for life. If target blood glucose is not achieved after lifestyle modification within 3 to 6 months, oral hypoglycemic shall be added. Now, initially, it is known as the honeymoon period in the diabetes, where without diabetes, sometimes people maintain the sugar. So those who are diagnosed diabetes once, sometimes they do well without drugs also, but they require every 3 months follow-up. Meticulous follow-up is required. Otherwise, you may miss the patient will feel, oh, I don't have a diabetes, and that's why I don't need medicine. So the target blood glucose is not achieved after lifestyle modification. Within 3 to 6 months, oral OHA, oral hypoglycemic agents shall be added. Metformin. Metformin is medically does not produce hypoglycemia. though it is labeled as a oral hypoglycemic agent, it's a misnomer. Metformin is used in ovarian polycystic ovary disease. The metformin is used. It does not produce hypoglycemia. It controls the sugar. It improves the insulin resistance, and that's why it improves the diabetes. So, metformin leading to hypoglycemia is not phenomenal. That's why I want to bring to notice. So, whenever the sugar is high, you start with first of all metformin. Second drug is the titrate the metformin to target the glucose value. Fasting should be 126. Sulfonylurea is another agent which can be given to patients who have a contraindication to metformin, or if metformin does not improve glycemic control alone. Patients with diabetes mellitus are at increased risk of developing tuberculosis. Tuberculosis and diabetes are co-disease. They work always hand in hand. That's why diabetic search for tuberculosis. Tuberculosis search for diabetes. This is to be kept in mind. Metformin should be used with caution in PLHIV with renal insufficiency, liver disease, active infections, including TB, and those with wasting or congestive cardiac failure due to risk of lactic acidosis induced by metformin. A dose adjustment of metformin should be considered when co-administering DTG with metformin in order to maintain glycemic control. It is recommended to limit the total daily dose of metformin to 1 gram when co-administration with the DTG. Monitoring the renal function, blood glucose is recommended when metformin and DTG are co-administered. NRTIs and PIs may cause increase or decrease in level of sulfonylurea, which may require dose adjustment of sulfonylurea. Is a glycinase, glipizide, or glibenclamide. There are sulfonylureas. Doses can be adjusted as needed based on blood glucose monitoring. The care provision and referral, screening, diagnosis, and management through lifestyle modifications can be provided by trained medical officer. Initiation of the oral therapy shall be done by the physician. Continuation of the treatment can be provided by trained medical officer in PLHIV with controlled diabetes. Management and follow-up by physician are recommended in patients with uncontrolled hyperglycemia despite maximum dose of metformin and sulfonylurea, patients with foot ulcer, patients with vision impairment. Now, cardiovascular risk factors. The cardiovascular risk factors are those are dyslipidemias, high fasting cholesterol level, high LDL. HDL is a good cholesterol, LDL is bad. There's a common thing we have to maintain. High LDL and low HDL, both are bad. Or in diabetic populations, what you see is a high triglyceridemia with normal LDL is also commonly observed. Obesity, when BMI is more than 30, and increased waist circumference, man more than 102 centimeter and woman 88 centimeter, risk of cardiovascular disease is more. Male are having more risk of cardiac disorders because in a menstruating ladies, the estrogen is there to protect the coronaries. Physical inactivity, tobacco use, excessive alcohol consumption, unhealthy diet and nutrition, and family history of sudden cardiac death or cardiovascular disease to be kept in mind in every time. Ask for history of heart disease, stroke, diabetes, hypertension, any anginal pain, breathlessness. Diabetic people sometimes may not have chest pain. They may just only complain the breathlessness on exertion. So any angina, breathlessness on exertion, and lying flat. Lying flat, also patient become breathless. What we say, PND, paroxysmal nocturnal dyspnea, or when a patient is lying flat, become venous rate increasing, developing breathlessness, you make him sit and breathlessness relief. So this is known as dyspnea on exertion or dyspnea on lying flat position. Numbness or weakness of the limbs, loss of weight, increased thirst, polyuria, puffiness of the face, swelling of the feet, passing blood in urine, that is hematuria. Any past or present treatment or medication. History we should ask. Lifestyle, sedentary or active. Premature heart disease in a history in the form of a any young death due to heart attack in the family, sudden death is there or not, we should take history. Stroke in the first degree relative on maternal side and paternal side, both sides we should take history. If there is a premature at early age, if they have developed any atherosclerosis or signs are there in the form of a heart attack or a cerebrovascular stroke. We should assess BMI, waist circumference. Now BMI also the app available. We can measure. We can write age. We can write weight in kilogram and height in a centimeter or meter square. The automatic calculators available. Use that. BMI and waist circumference, basal blood pressure, signs or symptoms of diabetes are there or not. Examine the signs such as pitting edema fit. Now pitting edema fit is seen on the shin of tibia 5 centimeter above the ankle. Heart murmurs are there or not. Basal capitations on the lungs are there. It's a sign of left ventricular failure. Tenderness on the abdomen, we should look. And lipid profile also we should measure whenever it's available. History of shortness of breath, loss of weight, pitting edema, hematuria, heart murmurs, basal capitations in lung, tenderness abdomen are the criteria where we should refer the patient to the physician. Follow lifestyle modification every time mentioned under lifestyle modification, which is mentioned in the health promotion. So diabetes, hypertension, stress everywhere. The lifestyle modification must be ensured during follow-up also. See that now the sugar is controlled, so I'll take more mango, I'll take more sugar. That should not be permitted. If the lipid profile is high, abnormal dyslipidemia is there, you treat with the statin for all patients with established cardiovascular disease, for patients having dyslipidemias. For managing dyslipidemias, in PLHIVs on ARV with known impact on lipid metabolism, PIs and efavirenz, single drug substitution to lipid-friendly drug is recommended if feasible. If lipid profile does not improve with the lifestyle modification, lipid-lowering drugs like statin, atorvastatin may be added. Starting dose may be 10 milligram, a maximum 20 milligram. If the patient is on PI, maximum dose of 80 milligram once daily, if not on PI. This atorvastatin is known to produce proximal muscle weakness. So once you put the patient on atorvastatin or any other statin, they will have a muscle involvement and proximal muscle weakness. So whenever he's getting up from the toilet, he'll have difficulty. So it is not the indication to stop the medicine. You monitor the symptoms regularly and patient will adjust. So we have to measure the other, refer to physician, where we may require CPK-MM and other monitoring. Okay. Simvastatin and lovastatin are also another molecule used for the dyslipidemias. Now, mental health and PLHIV. PLHIV are prone to develop psychological element like they may experience regarding HIV in their surroundings. PLHIV may face multiple types of psychological issues like depression, anxiety, and internalized stigma due to disease, etc. Any such issue can significantly hamper the adherence to treatment and mental well-being. Depression is 2 to 3 times more prevalent in PLHIV than in a general populations. All PLHIVs should receive basic screening for depression before initiating ART and thereafter every 6 months using the following 2 questions. Number 1, during the past 2 weeks, have you often been bothered by feeling down, depressed, or hopeless? Number 2, during the past 2 weeks, have you often been bothered by little interest or pleasure in doing things? These 2 questions we should repeatedly ask. Thorough screening for depression using the PHQ-9 screening tool and scoring pattern for PLHIV answering yes, any other above questions to be applied. This is a table where we have 9 questions are there and we assess. We ask the questions, little interest or pleasure in doing things. What is asking? If it is not 0 to 3 grades are there. So for all 9 questions, we should ask, and ultimately we should have a total score. Where does the patient falls? If the score is 0 to 4, condition is depression unlikely, repeat screening as per schedule is recommended. If the total score is 5 to 9, mild depression is there, provide supportive counseling and continue to monitor. If the patient is on efavirenz, substitute with the different ARV after ruling out treatment failure. If the score is 10 to 14, moderate depressions, provide supportive counseling to trained counselor. For anything above 10, moderate to severe depressions. When the score is more than 10, provide the supportive care. If the patient is on efavirenz, substitute with the different ARVs after ruling out treatment failure and refer to psychiatrist for further assessment and antidepressant medications. The social support, they explain about depression and assure that it can be managed. Feeling of hopelessness, worthlessness, negative emotions are part of depression and will revert with proper counseling and treatment. Inform on course of counseling and treatment. Identify supportive family members and involve them as appropriate. Involve peers and community supports groups also. Self-management skills like continuity as prescribed. Identify activities that they use to find interesting, where they feel happy and pleasurable. Encourage participants in these activities. Get regular and sufficient sleep for at least 7 to 8 hours. Physical activities to be encouraged. Contact ART center or healthcare workers immediately if thought of a self-harm. Suicide also we see regularly, we read in newspaper. So wherever you find that there are something serious depression is going on, we should take extra care. We may refer the patient for admission also. Reduce stress by identify and try to reduce the stress point. We all of us have a stress button. I should have a pen on my left pocket or left side on. Arey, Baba, pen is sufficient. It should be right in the pocket. Either on left side or right side, that matters. That doesn't matter. So that's why those who are listening, themselves I'm saying, please identify your stress button. किसको याद करने से हमारा मगज तेज हो जाता है. You and avoid contact with some people. So we type A personality is a problem. So identify your stress button. शांति से बैठ कर list बनाइए. Prepare a list. Which point irritates you and try to avoid. Same way to explain to the patient also. आप क्या याद करते हैं तो आपको गुस्सा आता है. That is important thing. So that stress button must be identified and we should have a different response to whenever such buttons are. Many times other our bystanders, our colleagues, they may press that button. And that's why they उसको बोलते हैं दुखती नस पे पाँव रखना, इसको बोलते हैं हिंदी में. So ध्यान रखना पड़ेगा. So identify stress buttons, stress points. Identify and discuss stress increasing points such as health issues, family and relationship problem, gender bias, gender-based or partner violence, finance, stigma, and discrimination in the community. Identify and discuss problem-solving techniques, suggest stress management such as meditation and relaxation techniques. Depression can be managed by combination of the medical and psychological interventions. Whenever needed, antidepressants should be prescribed by psychiatrists. Antidepressant treatment is generally given for 6 to 9 months, and doses should start with the minimum recommended dose and increase gradually. It takes 2 to 4 weeks for maximum therapeutic benefit and improvement in symptoms to be achieved. Antidepressants should not be stopped abruptly. Dose should be tapered gradually. They are the hints we have to given to the patient as well as relative. Those are coming for the follow-up together. There are 2 main class of antidepressants: tricyclic antidepressants, amitriptyline group, and one is SSRI or fluoxetine group. There are no drug interaction between NRTIs, or integrase inhibitor and amitriptyline or fluoxetine. So they are safe. PIs increase the drug level of amitriptyline or fluoxetine, but no adjustment of dose of both these drugs is required. Amitriptyline or fluoxetine do not affect ARV drug level. Amitriptyline and PI should be administered with caution as both prolong the cardiac QT prolonged interval and ECG monitoring is required. Mental health disorders during childhood and adolescence are defined as delays or disruption in developing age-appropriate thinking, behavior, social skills, or regulation of emotions. Prevalence of the mental health condition in children and adolescents between 6% and 12%. Prevalence of 7.3% in children and adolescent ages and adolescent of 13 to 17 years of age. Overall, 8% to 13% of children are estimated to need mental health services. This is about the various points to be kept in mind. That is a persistent sadness, 2 or more weeks withdrawing from or avoiding social interaction, hurting oneself or talking about hurting oneself, talking about death or suicide, outburst or extreme irritability, out of control behavior that can be harmful, drastic changes in mood, behavior or personality, changes in eating habits, loss of weight, difficulty in sleeping, frequent headache or stomach aches, difficulty in concentration, changes in the academic performance, or avoiding missing school. This is all about the mental health. And now last part of the topic is a common cancer among the PLHIVs. You to whom will screen? Those who are having use of tobacco, screen all of them. Counsel on adverse effects of tobacco and encourage to quit tobacco use. Promote healthy dietary practice and physical activity. General guidance for PLHIV on treatment for cancer. PLHIV receiving radiotherapy or surgical intervention shall continue taking ART. That is one. In PLHIV receiving chemotherapy, treating physician and oncologist shall discuss the prepared individualized plan considering potential interaction with the antibiotics and toxicity profile. Create awareness about the early warning signs of cancer like following. Changes, these are important things to be remembered. Change in the bowel or bladder habits, diarrhea, constipation alternate, frequent diarrhea, frequent constipation. Have a look. Am I missing cancer or not? Wound that does not heal. Unusual bleeding or discharge from any part of the orifices. Thickening or lump in the breast or introwing of the nipple. Then indigestion or difficulty in swallowing, dysphagia, obvious changes in the wart or a mole, sudden change color or shape of the mole, which were there for many years. We need to screen. Nagging cough and hoarseness of voice is also to be screened for are we missing cancer or not. Educate a patient on self-examination and reporting for unusual signs and symptoms. Every birthday or every any day, their marriage anniversary, their wedding anniversary, self-examination breast is to be promoted. Examine patients for warning signs and routine examination of oral cavity, breast, and cervix. Refer any patient with suspicious lesion of accurate diagnosis and appropriate treatment. The screening of the cancer, all women and girls having with HIV who has initiated sexual activity. The screening frequency at all ART initiation, repeat screening within 3 years if the initial test is negative. Women who have been treated should receive follow-up screening at 1 year. Any other time, if related signs or symptoms are reported, screening for cancer is required. Method of screening, visual inspection with acetic acid. 3 to 5% acetic acid is generously applied to the mouth of the cervix area, and presence of any aceto-white lesion is noted or not, that is to be observed. Observation, normal squamous epithelium of the vagina appears, normal squamous epithelium of vagina appears pink. Here it becomes white. Columnar epithelium of the uterus appears red. In conditions like inflammation, benign and malignant growth, the epithelium contains a lot of cellular proteins because of increased nuclear activities, thereby giving a dramatic dense white patch known as VIA positive. And sometimes they bleed on touch also. Refer, if the screening is positive, refer to gynecologist, lady medical officer where available, or NCD clinic at CSC district hospital for confirmation and further management of cancer. All women living with HIV above 30 years of age, risk factors are reproductive and hormonal factors, old age at first pregnancy, elderly primary and beyond, early menarche before 12, late menopause, never had children, women who take menopausal hormonal therapy for 5 years or more after menopause. They are all, we should be more careful in this group. Risk factors, family history, risk of breast cancer increase in women with the first degree relative with the history of breast cancer. So in the family everyone, they have more chances. Other factors are being obese after menopause, physical inactivity, and alcohol intake are also individual risk factor for cancer in the women. Breast awareness, women should be counseled on breast awareness. The first person to detect any lump in the breast is the woman herself. So they must have a regularly. While taking bath, they must apply the soap and that they should examine the, all women must be taught in a self breast examination. Teaching a woman to be aware of any of the following signs at the earliest possible. Change in the size of the breast, nipple that is pulled in or change in position or shape, rash on or around the nipple, discharge from the one or both nipples, puckering or dimpling of the skin, lump on the thickening in the breast, and constant pain in the breast or armpit, one should be screened for cancer. All women living with HIV of more than 30 years should be screened using clinical breast examinations. Clinical breast examination is to be performed by trained physician or nurse. The screening shall be done at a RD center and repeat screening within 3 years if initial test is negative. Any other time, if related signs symptoms appears, they should be screened. Method is a clinical breast examination. Both breasts are visually inspected and palpated in different position from all sides, including breast tail in the axilla. All women living with the HIV above 30 years of age, through clinical breast examination, the following are noted. Any change in the symmetry in the breast shape and size, skin changes, dimpling, retraction or ulcerations, the level of both nipples, retraction of the nipples or inverted nipples. On palpation, any discharge from the nipples, color of the discharge, swelling, lump, consistency of lump. Examine the swelling in the armpit, axillary area, above the collarbone, supraclavicular area, and root of the neck, that is infraclavicular area, for the secondary lymphadenopathy. Refer clinical breast examination is negative. If no signs and symptoms are noticed, follow up as per routine screening schedule. And if there is a positive finding on the examination, they are noted during the clinical breast examination, refer to surgeon for further evaluation, USG, biopsy, diagnosis and management. So, for the tobacco use and risk factor, tobacco chewing is the single most important risk factor for oral cancer. So, they all must be screened. Can I stop? Time ho gaya, theek hai. So please, those who are using tobacco, they must be screened for the oral cancers. The last slide, let me finish fast. We should promote them for adequate emphasis shall be made for the citizen. They should stop the tobacco. All PLHIV more than 30 years of age should be screened using oral visual examinations with proper light. Screening shall be done at all ART stations. Repeat screening every 3 years. Method of screening is oral examination. Observation, what we should observe: leukoplakia, that is violin, erythroplakia, palatal changes associated with the reverse smoking and BD smoking. Those who keep the burning end inside, submucosal fibrosis. If any abnormality is noted during the oral examinations, PHIV need to be referred to a surgeon or ENT surgeon specialist for further evaluations, diagnosis, and management. Thank you very much for the patient's hearing. And a bit cross the limits, but time is concerned. Let's see. Thank you very much for your patient's hearing. And if any questions are there, I welcome.
So thank you so much for the facilitating this session, sir. Any questions from the participants? Please feel free to unmute your mic. You can also type in the chat box. Any questions from the participants? So thank you so much. So can we quickly run the feedback form, please? Praveen, sir. The feedback poll is now visible on your screen. Participants are requested to please take up the feedback poll. There are 4 questions in all. Please scroll through the questions and answer all of them. Requesting all the participants to please take up the feedback poll. Thank you, everyone. So can we conclude the session now?
I'm highly thankful to all the participants.
Thank you,
My
sir.
number is, if any question is there or if I can help anyway, they can communicate me directly. I
Thank you,
welcome
sir.
all of you. Whenever you find time, come with your family members, in-laws. We have 2, Somnath and Nageshwar. 2 Jyotirling bhi hai. So I invite to Gujarat also. Thank you very much.
Thank you to all the participants. We'll conclude this session now.